Bismillahirrahmanirrahim. Here is Amna Roheel. Today we will discuss the measures of disease frequency. This is another topic of our online course, MSc in Health Innovation and Data. The main contents of our today's topic is the introduction to disease frequency measures, in which we will discuss incidence, prevalence, cumulative risk, mortality rates, and also we will discuss the relationships between measures. First, the introduction to disease frequency measures. What are these? These are the quantitative tools that epidemiologists and health data scientists use to describe how often disease or health events occur in the population. These measures are fundamental to understanding disease burden in communities, identifying risk factors and causes of disease, evaluating prevention and treatment programs, planning healthcare services, tracking disease trends over time and across population, comparing disease occurrence between different groups. Two fundamental questions we will discuss in this topic. Actually, the disease frequency measures, these are the tools that we use to measure the previous records about their diseases and current diseases and the diseases which will happen in the past and which can be happen in the question number one is how many people currently have the disease. This is measured by the prevalence. Represent the disease burden at a point in time. In all these measures, the time is very important. We will discuss with the examples further. Important for healthcare planning and resource allocation. Question number two, how many people are developing the disease? The first one is the currently have the disease and the second one is the developing the disease. This is measured by the incidence. Represents the rate of new disease occurrence, critical for my understanding disease etiology and risk factors. Now, what are the key components of disease frequency measures? There are three essential components: numerator, denominator, time specification. And numerator is the number of health events, like how many cases and how many deaths and how many disease cases are there. Denominator is a population at risk. Actually, when we discuss some past and the future perspectives of the disease measures, we also consider a large population to conclude the result. And the number third is the time specification, is the time period of the observation. Examples framework. Measures equal to number of events like the diseases and cases and the population at risk and the multiplier during specific time period. We will discuss all these formulas and the framework for. Number one is the incidence. Definition and the concept. Incidence measures the occurrence of new cases of disease in a population during a specified period of time. It is a dynamic measure that captures the transition from health to disease. Key characteristics of the incidence. In this topic, only counts new cases, not the existing one. Requires disease-free population, because that the population that we will consider is a disease-free at the start of observation. Always has a time dimension. We will consider a time window or a range of time in which we will study on the incidence of any disease. Always have a time dimension, measures the risk or rate of developing disease, used primarily in cohort studies and prospective research. Who is at risk? The denominator in incidence calculation includes only people who are capable of developing disease. This means in excluding people who already have disease, we exclude them. People who are immune or have had the disease previously, we exclude those people. People who have been removed, like the specific disease, for example the breast cancer or the uterine cancer, if the patient already have the disease and they have the surgery to remove that part, we will not include in the study. People who are biologically incapable of getting the disease, for example man for ovarian cancer, obviously example in a study of breast cancer, incidence among women include women without breast cancer. Okay, because in the incidence measures, we only include the population which don't have the disease previously. Exclude which we will exclude women with previous breast cancer, women who had bilateral mastectomy. Types of incidence measure. There are two types of incidence measure: the cumulative incidence and the incidence rate. We will discuss both with cumulative risk. Cumulative incidence. Cumulative incidence, also called incidence proportion, incidence risk, or attack rate, is a proportion of a disease-free population that develops the disease during a specified time period. It answers the question, what is the probability and what is the risk that a person will develop the disease during a given time period. This is the formula that we will use to calculate the cumulative risk. Cumulative incidence equal to number of new cases during time period divided by population at risk at the start of period. We can understand these formulas and the whole scenario of the cumulative risk with it. And we conclude their results in a form of range, that is 0 to 1, and that is the proportion 0.05, percentage 5%, and per thousand population it means 5%, 5 per thousand, it means 5 are the cases, and 1000 is the total population, and the 1000 population per 10,000 or the 1 lakh for the rare diseases. Key assumptions. What are the key assumptions that we consider to calculate the cumulative incidence? Complete follow-up of the all individuals in a population, constant risk throughout the observation period, fixed population with no losses to follow up. Everyone is followed by for the same ratio. 10 already have the COVID. Exclude them because we only consider the new cases during our time period. 150 minus 10 equal 140, and our cumulative incidence is the 45 new cases over 140 at-risk residents. And according to this, our risk is 32.1% over 4 weeks. And then example number 3, foodborne illness. In a wedding reception with 200 guests, 80 people develop food poisoning within 48 hours. How we can calculate them? 80 people, that's the new cases in a specific time period, that is the 48 hours, and our cumulative incidence will be the 40% over 48 hours. Interpretation: the attack rate for foodborne illness at this event was 40%. This high rate suggests a common source outbreak, likely from contaminated food served at the reception. When to use cumulative incidence? When there is the follow-ups time is similar for all participants, there are some specification that should be followed when we will measure the cumulative incidence. Study duration is relatively short. There is minimal loss to follow up. You want to express risk as probability and also percentage in outbreak investigation for clinical trials with fixed follow-up. But there are some limitations, like does not account for varying follow-up times, like if a specific population in a specific period of time, few people have the regular follow-up, but the few others are not follow the rules, they do not follow. There are a lot of reasons. That's why this is the limitation in the cumulative incidence. And in that scenario, we can calculate another type of incidence that we will discuss later. Cannot handle losses to follow up well. Losses information when people are followed for different durations. That is the thing. Not appropriate for open population with entries and exits, because we consider only specific type of population during a specific time and specific incidence rate. That if some people do not follow the strict plan of the follow-up times, then we can calculate the incidence rate. Like the 1 person for 5 years equal to 5% years, 5 people for 1 year each is a 5% year, 10 people for fixed 6 months each is a 5% year. We can calculate by All contribute the same amount of percentile but represent different study design. And now we will discuss the detailed examples like the cancer incidence study. A study follows 1,000 people for lung cancer. The follow-up varies 400 people followed for complete 5 years, that is equal to 2,000 person years. 300 people followed for 3 years, that is a 900 person years. 200 people followed for 4 years, that is 800 person years. 100 people followed for 2 years, that is the 200 person years. Total person time, we will calculate the total person time, that 2000 plus 900 plus 800 plus 200 equal to 3900 person years. Number of lung cancer cases equal 200. So how we can say like the where our incidence rate is the 0.0513 cases per person year. After detailed calculation, total person time is the 1850 person year total HIV infections. Now the example number 2, HIV infection in a cohort. Study follows 500 HIV negative individual during follow-up. Person A followed 2 years, then developed HIV. 2% year, and the person B followed 5 years, no HIV, that's the 5% year. Person C followed 1 year, lost to follow-up, equal 1% year, and the person D followed 3 years, developed HIV 3% years. Then we can calculate the incidence rate is the 25 cases over 1850% years. So our incidence rate will be 0.0135 per person year. We can also represent our results in a percentage like 1.35% per year approximately. Now example number 3, comparing incidence rate versus cumulative incidence. Study of 1000 people for heart disease over 10 years. 200 people develop heart disease. Not everyone followed for the full 10 years. Total person time of observation is 7,500 per. Cumulative incidence. If we ignore the variable follow-up, then cumulative incidence should be 20% over 10 years. But over the follow-up times are different. So we calculate the incidence rate. That is the 26.7 per 1000% years. When to use incidence rate? Incidence rate is preferred when follow-up times vary substantially between participants. There are losses to follow-up. Study has an open population. We want to maximize efficiency of data use. Studying rare diseases that require long follow-up. Advantage of the incidence rate accounts for variable follow-up, and there are some flexibility as compared to the cumulative incidence. Accounts for the variable follow-up, uses all variable data efficiently, handle losses to follow-up, more precise than cumulative incidence than when follow-up varies, comparable across studies with different durations, appropriate for dynamic populations. Converting between measures. As we discuss in our main contents, we will discuss their relationships. So how we can convert cumulative incidence with the incidence rate. Under certain assumptions, constant rate rare diseases, you can approximate cumulative incidence parallel to incidence rate multiplied time period. For example, if incidence rate equal to 20 per 1000% years, then 5-year cumulative incidence can be 20 divided by 1000 multiplied by 5 equal to 10%. This approximation is only valid when disease is rare. Risk is constant over time, no competing risk. We only convert these measures when the diseases are rare. Now further we will discuss the prevalence. Prevalence measures the proportion of a population that has a disease at a specific point in time or during a specific period. It includes both new and existing cases. It answers when proportion of a population currently has the disease. This is the formula, that is the number of existing cases at a specific time divided by total population at the time. And we also represents its results in a range, that's 0 to 1, and the percentage is 0 to 100. Types of prevalence. Point prevalence. The proportion of population with the disease at a single point in time. For example, in January 1, 2025, the prevalence of hypertension in our clinic population was 25%. This is the single point. Now the period prevalence, the proportion of a population with the disease at any time during a specified period. That is the formula. Period prevalence, cases at the start plus new cases during the period over population. Example, during the year 2024, the prevalence of influenza was 15%, meaning 15% of population had influenza at some point during the year. Period prevalence is less commonly used and can be confusing because it mixes prevalent and incidence cases. Because in the incident cases, we only consider the new cases, but that's why it can mix with the prevalence. Now the details example, diabetes prevalence. A community health survey on March 15, 2025 screens 10,000 adults. The survey finds that 1,200 people currently have diabetes, including those diagnosed years ago and recently diagnosed. Calculation, 1,200 divided by 10,000, that's at 12%. The point prevalence of diabetes on March 15, 2025 was 12%, meaning that 12% of adults in a community currently have diabetes. Example number 2, asthma in children. A school health screening of 2,500 children. 200 children have active asthma. 50 children have a history of asthma but are currently asymptomatic. Calculation for the active asthma, 200 divided by 2,500, that is the 8%. In the calculations, ever had asthma is the 200 plus 50, because we include both, like the existing one and the present one, divided by 2,500 equal to 10%. The current prevalence of active asthma is 8%, while the lifetime prevalence is 10%. Example number 3, depression over time. Annual surveys measure depression prevalence in a city. In 2020, 50 cases out of 20,000 adults, that is 2.5%, and the same we calculate with over the years. That in the 2021, 600 cases out of 20,500 adults, that is 2.9%. In 2022, 3.8%. In 2023, it's 4.9%, and 2024 is the 5.5%. Now we can calculate and we interpret our results, like the depression prevalence has been increasing over the 5-year period from 2.5% to 5.5%, suggesting either increased incidence, longer duration of illness, improved reduction, or reduced stigma, leading to better reporting. Relationship between prevalence, incidence, and duration. Prevalence is influenced by both the incidence of disease and the duration of disease. Formula: prevalence parallel to incidence into average duration of disease. We only hold this relationship under steady state condition, like the stable population, constant incidence, and duration. Now we have relationship: high incidence plus short duration equal to low to moderate prevalence. Low incidence plus long duration equal to moderate to high prevalence. High incidence plus long duration equal to very high prevalence. Low incidence plus short duration is a very low prevalence. Now we will discuss their results. Understanding the relationship scenario number A. Influenza incidence is the 100 per 1000 per year, like the 10%. Duration is a 7 days, and expected prevalence is 0.1 multiplied 0.019 equal to 0.19%. Even though many people get the flu each year, few have it at any given time because it's a short-lived. Now the scenario number B, diabetes. Incidence is 0.008. that is the 8 per 1000 per year, and the duration is the 30 years. Expected prevalence is 24%. The factors that affecting the prevalence. Prevalence can increase due to increased incidence, like the new cases will arrive, and the longer survival, people living longer with the disease, immigration, improved diagnosis, decreased cure or recovery rate. We can also discuss these factors with examples further. And the prevalence can decrease due to decreased incidence, fewer new cases, shorter survival, emigration, increased cure rate, improved treatment, leading to faster recovery. For example, HIV/AIDS prevalence changes historical context. In 1980, there is a time period of the 10 years, like the 1980s to 1990. HIV prevalence was relatively low despite rising incidence because survival was poor. In 2000 to the present, HIV prevalence increased significantly even as incidence stabilized or decreased because antiretroviral therapy dramatically increased survival long duration. Interpretation. This demonstrates how prevalence can rise even when incidence falls due to changes in disease duration. When to use prevalence. Healthcare planning, estimate service needs, resource allocation, determine necessary facilities and staff, disease burden assessment, understanding overall impact cost effectiveness studies, calculating healthcare cost, cross-sectional studies, one-time survey, chronic diseases, condition with long duration. And also in the screening program planning, estimating positive predictive value. What are the limitations? Every measures of the disease frequency have a limitations. The number one is not useful for studying etiology, mixes new and old cases, affected by disease duration, difficult to interpret, is high prevalence due to high incidence or long survival, cannot establish temporarily, not appropriate for rare or acute conditions, subject to survival bias, only includes survivors. This is the table that is the comparison of the incidence and the prevalence. We all discussed these factors previously. This is just in a compiled form, and represents in a table form. When to choose which measures? Choose incidence when you want to study disease etiology and causes. The one limitation is the advantage of the other measure. Study disease etiology and causes, identify risk factors for disease development, evaluate preventive intervention, understand disease trends over time, compare disease occurrence between groups, determine temporal relation. When use prevalence, when you want to estimate healthcare service needs, look at resource and budget planning, measures overall disease burden, screen for positive predictive value calculations, conduct quick assessment, study chronic condition for service. Now we will discuss the mortality rates. Mortality rates are the special type of incidence rates where the outcome of interest is death rather than disease. They are among the most important and commonly used health indicators because death is a clearly defined endpoint. Death registration is usually complete and reliable. Mortality data is widely available. They reflect both disease incidence and severity. They are comparable across population and time. CMR, like the crude mortality, will be 8 per 1000 population per year. Example number 2, comparing two city scenarios. In the city 1, the population is 500,000, deaths are 4,500, then our CMR will be 9 per 1000. And then the similar way, the city number Y, that CMR will be 7 per 1000. Now we will compare and interpret our results. City X has a higher crude mortality rate than city Y. This could be due to differences in their age, because there is no consideration of their age groups in this calculation. This is the limitation of CMR. Heavily influenced by age structure of the population, not suitable of comparing population with different age distribution, like the many diseases which are linked to the old age. That's why we will not consider, that's not suitable. Older population naturally have higher CMR, can be misleading when comparing developed versus developing countries. Number B, cause-specific mortality rates. The number of deaths from a specific cause. In the CMR, we will not discuss the specific cause, we just a common cause. In the cause-specific mortality rate, the number of deaths from a specific cause divided by total population at risk. This is the formula that all usually expressed per 1 lakh population per year. This is the example. Heart disease mortality scenario in 2024. A state with population 50 lakhs had 12,500 deaths from heart disease. And after the calculation, the result will be 250 per 1 lakh year. Example number 2, comparing leading causes of death scenario. Country B, population 20 million in 2024, heart disease deaths 160,000, and the rate will be the 800 per 100,000. Cancer deaths are the 700 per 100,000. Stroke deaths are the 400 per 100,000. Respiratory disease deaths are the 300 per 100,000. Diabetes death 200 per 100,000. Now we can interpret them. Heart disease is the leading cause of death with the highest mortality rate, followed by cancer, and these cause-specific rates help prioritize public health intervention. Uses of cause-specific mortality rates. Identify leading causes of death, monitor specific disease trends, evaluate disease control programs, compare disease burden across population, guide public health priorities, track progress toward specific mortality rate. The number of deaths within a specific age group divided by the population in that age group. That is the formula, and we expressed in thousand expressed per thousand population in that age group. Age specific mortality scenarios, city population data for 2024. The first column, that is the age group, the second is the population, third one is the death, and at the end ASMR per thousand. From the specification to the age, we can calculate the specific mortality rate. Now the calculation for 65 plus age group, ASMR is a 50 per thousand. Mortality rates increase dramatically with age. The elderly have a mortality rate of 50 per thousand, which is 25 times higher than the young adults. Use of age-specific mortality rates. Identify age group at higher risk, which disease is more common in which age group. Compare mortality patterns. Plan age-appropriate health services. Basis for age standardization. Track health improvements in specific. And now at the end, we will discuss the infant mortality rate, like the IMR. The number of deaths of infants less than 1 year of age per thousand live births in a given year. IMR is one of the most important indicators of population health and healthcare quality. That is the formula: infant mortality rate equal to deaths in infant, that is less than 1 year, divided by total live births, multiply 1000 expressed per 1000 live births. Components of the IMR: neonatal mortality rates, deaths in first 28 days, most sensitive to obstetric and immediate newborn care. Now the example number 1, national IMR scenario. In 2024, country C had live births 4 lakhs. Infant death under 1 year is 2400. Now we can express our IMR is the 6 per thousand live births. We can interpret our results like that. The infant mortality rate was 6 per thousand live births, meaning that 6 out of every 1,000 babies born alive died before their first birthday. This is considered a low rate, typically of the developed countries. Now, the example number 2, comparing country scenario. Infant mortality rate by country 2024. Norway is 2 per 1,000. Developed country, excellent healthcare. United States is the 5.4 per thousand. India 28 per 1000, and the Sierra Leone is 80 per thousand. Least developed, poor healthcare access. Interpretation. Infant mortality rates vary dramatically worldwide, reflecting differences in healthcare quality, prenatal care, nutrition, sanitation, and socioeconomic condition. Countries with the rates below 10 per 1000 generally have well-developed healthcare systems. Why IMR is important? Sensitive indicator of overall population health, reflects quality of maternal and child health care, indicates socioeconomic development level, influenced by multiple factors, healthcare, nutrition, sanitation, and education, used for international comparison. Like in the epidemiological studies, we can compare IMR if we discuss the mortality rates in the infants. Target for health development goals like the UN Sustainable Development Goals. Thank you so much. I hope you can understand all the measures and their relationships.